All right. Okay. Okay. I think we're good. Can everybody hear me?
You are live. Yes, thank
Okay,
you.
very good. Okay. All right. Thank you. Thank you, Zach. Thank you so much for the invitation. It is my I'm honored to be here. It's such a pleasure working with the Interaction equipment, and I'm very blessed to have the best equipment for the experiments that I did for the dissertation. So what I'm about to share today is one of the aims of the dissertation of my project, and it talks about the scapular dyskinesis and the scapular dyskinesis test, which is the test that we use clinically to be able to detect whether we can detect or the presence or absence of scapular dyskinesis. All right. So just like any other presentations, we have to have course objectives. So by the end of this presentation, each of the participant, whether you are live or you'll be watching this recorded, you'll be able to define scapular dyskinesis, and we're going to call it SDK in this presentation by understanding its importance. The participant will also be able to define the yes and no method of the scapular dyskinesis test. So it's like a variant of it by indicating its purpose. We're also going to be able to differentiate the controversies surrounding scapular dyskinesis through the most current literature. And finally, evaluate the clinical utility of the YNSDT. So we call the yes and no method of the scapular dyskinesis here for this presentation's sake, YNSDT, by understanding its validity against the EMG. So in other words, is the scapular dyskinesis test measuring or looking at the same exact thing that the EMG is seeing? Is that fair to say? All right, so let's do that. All right, but before we do this, I want you to just watch this video and just try to pay attention to the shoulder blades. All right. So I'm sure if you paid attention to it, I'm sure most of you have seen something a little funky going on the left on the left side of the shoulder and or the scapula, and then a little bit on the right side as well, in and out. But what you have just witnessed is what we a phenomenon or movement phenomenon called scapular dyskinesis. So what is it? By definition, it is an abnormal movement of the pattern of the scapula during active motions. So based on Burkhardt, it is already defined as an abnormal movement, right, of the scapula. It came from, according to the Merriam-Webster dictionary, it came from the Greek words dus and kinin, which means that it's a bad movement. So here we call it bad movement of the scapula. But then Kibler defined it a little bit more specifically, that it is only significantly significant if it's present in the symptomatic patients and it's showing as asymmetry, when compared to the other side. So just like similar to what you've seen earlier in the video, there's a little bit of asymmetry going on in there because of what's happening more on the left side. However, Kibler also made it a point that it is not a diagnosis, but it is simply a modifiable clinical impairment that may indicate a deviation from the optimal scapulohumeral rhythm. All right. So we'll talk about the scapulohumeral rhythm next. So right now we have talked about it as pretty much an abnormal movement of the shoulder blade, and that's what the definition is. But we would never really understand it unless we understand what normal means. So normal like I mentioned earlier, originally came from the term scapular humeral rhythm, which was coined by Codman in the 1930s. Everybody knows this. Most clinicians, most physical therapists, or I would say all, would be very familiar with this term. And what it means is that there's a notion that there's a 2:1, roughly. That's because that has been, it's just an average, a 2:1 ratio between the humerus and the scapula. So in other words, for every 2 degrees of motion of the humerus and the glenohumeral joint, there is a 1 degree of motion happening on the scapula, specifically in the upward rotation. So those are the motions. However, based on the improvement on imaging, and specifically in motion capture and motion analysis, we now know that there are more than just upward rotation of the scapula during the scapulohumeral rhythm, that there are technically 6 degrees of freedom happening on the scapula. So those are the upward down rotations, the anterior posterior tilts, the internal external rotations. And these motions are a function of or a responsibility of the muscles. In other words, the muscles are the ones who are responsible for the motions. These motions that the kinematics of the scapula, and these are 4 major muscles: the 3 trapezii and the serratus anterior. Now, what causes scapular dyskinesis? It has been hypothesized or theorized that it is based on the altered scapular muscle activation, because we just mentioned earlier in the last slide that the motions or the movement are responsibility of the muscles. So therefore, if it is altered, more than likely this would be the case when it comes to the abnormality of the movement that that we presume that's happening on the scapula when we see one. And we understand this altered scapular activation as the responsible or the culprit for such poor movement of the scapula because of based on the pathokinesiological model or theory, which is based on pathokinesiology, the term pathokinesiology, which means that it's study of the movement dysfunction resulting from a pathology. So what that means is that if there is something not working, so in this case, say the muscles are not activating or activating poorly, then it must be the one that is responsible for the abnormal movement of the scapula. Now, why are we talking about this in the first place, other than describing it and all that? Well, the problem with the SDK is a lot of literature has been shown that it's been associated with almost every single shoulder problem that you can think of, right? From impingement, from rotator cuff problem, even all the way up to adhesive capsulitis. And the problem with this is that in general, according to the the bone and joint disease the musculoskeletal disease direct and indirect cost for just 3 years, from 2012 to 2014, is in an upward of close to $1 trillion. And then the other problem is that 1/3 of physician office visits for orthopedic conditions is specifically just for the shoulder. So basic math would tell you that that's about $300 billion a year. I mean, that's just a lot of money just for one body part, right? And we understand this. We understand this association of the shoulder problem, right? The presence of shoulder problem with a movement impairment based on another theory called kinesiopathological model, right? From the term kinesiopathology, which is the study of disorders resulting from impaired movement, which is an additional theoretical model. Now, if that is how important SDK is, how do we detect it then, right? Well, this is it. What you're seeing right now is a video recording, similar to the first video, wherein we do a test called Scapular Dyskinesis Test that was introduced to us by Kibler and his team almost 20 years ago. And it's simply 5 repetitions of bilateral weight based on the weight of the person. and moving it up and down, overhead, and pretty much waiting to see if there is that asymmetry or abnormality in the movement of the one of the scapula. So you're comparing to the other side, and the original version of this is that what do you call this? That there is a the presence or the absence of these four what we call definition of impaired movement, which is the prominence of the inferior angle, the medial border being or being more prominent, also known as winging, or maybe excessive or abnormality when it comes to premature elevation of the scapula, so on and so forth. This test has been shown to be reliable and valid specifically for symptomatic population, okay? And it has been validated using kinematics. So we're talking about motion capture for the scapula, and that's how they validated the study. I mean, the test itself. However, based on further studies, though, they found that the yes and no method, which is simply saying that, oh yes, there is a presence or absence of asymmetry between the two, were found to be more accurate and more reliable than the original four types right here. So, in other words, make it simple, and that's what we're getting. That's the one that we're studying right now. We studied about. Okay, so clinically, what are we doing with our with these patients that has presence after? So after we have used the scapular dyskinesis test and we determined that they have scapular dyskinesis, what do we do with them? All right, I'm sure most clinicians, orthopedic clinicians, would agree that we do what we call scapular focused exercises. These are exercises that are dosed for strengthening or endurance, depending on the need, and specifically for our symptomatic patients. And these are our classic I's, T's, Y's, and W's. Although there are more, but these are the classic ones. In other words, they're targeted towards the four scapular muscles that we've been talking about. And we understand this. We understand the reason why we focus on the scapular muscles when it comes to the presence of scapular dyskinesis, based on those theories again that we talked about, right? I think collectively we call this the biomechanical model. Now, so let's talk about the controversy. What is going on when it comes to scapular dyskinesis? So, scouring through the literature, this is what we have. In prevalent studies, okay, so meaning how common scapular dyskinesis is, it has been shown that 60 to 70% prevalence rate in symptomatic population. Okay, what I have not shown you earlier is that which I should have shown you though, but the prevalence of scapular dyskinesis in the symptomatic population is roughly the same. All right, so what does that mean? It implies that SDK is pretty much common even in the healthy population, right? So, I mean, what's the value of that if it's common to the healthy population anyway? And then there were studies, kinematic studies. These are motion capture for the scapula, and they looked at the dyskinesis, all these movements that's happening on the scapula of those with those symptomatic and those asymptomatic. Because remember, I told you that above that the prevalence pretty much the same. So they look at that and they found that there's no difference between the two groups. Well, what does that mean? It implies that maybe not be meaningful clinical presentation at all. All right. So we're starting to lose, if you think about it, if you keep reading these types of articles, you see like, well, why are we paying attention to scapular dyskinesis then, right? And then finally, there were studies that directly try to intervene on the scapular dyskinesis. So they did scapular focus exercises to be able to help improve the pain and the function, and hopefully they would be able to minimize the so-called movement impairment, right? This winging, this excessive winging, excessive tipping, and all that. And but when it came to the kinematics, it was very unclear. So what I'm saying is that it's helping these exercises that they did in these studies help the pain and the function, but did not necessarily affect the kinematics or the movement, right? That the scapular dyskinesis is defining as abnormal. Some of them had no change, and and apparently some of them, the kinematics, when they remeasured it, it apparently worsened. So what does that mean, right? So it means that kinematics might not be responsible for pain and functional limitation. They might not be related at all. Another thing, another comment on this one is that it has been also shown that a lot of these kinematic reference standards are really poor. I've seen that in my literature review as well. So that kind of somewhat explains probably why the effect on kinematics is not it's not explaining what has happened here as far as the improvement on pain and function. Now, more recently, however, there is this other study that says, and here is their main topic, it says that, or a headline, it says that the presence of scapular dyskinesis increased the risk of future shoulder pain by 43%. Ooh, now we're talking, right? This is quite scary now because we're talking about people who don't have shoulder pain yet, and it says that it can be predictive of somebody developing pain if they have the presence of SDK, right? And what's worse is that it can happen within 9 to 24 months from the time that it was been detected. Okay, quite scary, right? The only problem, I mean, the only what do you call this? Legitimacy, right? There's a big legitimacy on this particular study because this is a systematic review with meta-analysis and has a level 1 evidence, which is a level 1 evidence. And believe me, I have looked at this, read this article from top to bottom, and they did a pretty good job. So it's a collection of all these prospective studies. These are really powerful studies, and they follow these patients after they have detected the scapular dyskinesis, and about, saying that almost half of them develop shoulder pain when the scapular dyskinesis has been detected, as present. So what does this mean? It tells us now, it's suggesting that asymptomatic SDK should be addressed via, an epidemiological standpoint. What I mean by that is that we're now thinking or looking at not just the symptomatic. Remember, we're talking about SDK in the symptomatic population. We're talking about asymptomatic population that we need to start addressing it. So just like any other modifiable risk factor, right? So now we're treating SDK as a modifiable risk factor. If that is the case, it means that we have to also probably, or more than likely intervene, right, in a preventative standpoint. That's what I mean by epidemiological standpoint. And the problem is that before we move on treating asymptomatic, in my view, we need to, hold our horses, so to speak. Because the problem with that is that it might lead to pathologization of the, of the modifiable risk factor. In other words, we are now saying that there is the SDK is a pathology. And then, like I said earlier, it can lead to intervention, which will, become, it means that we're medicalizing it. And medicalization means that we are now going to spend more money on top of we are already spending on those symptomatic patients. So that's the reason why I say we need to hold on to this. So, so the idea for me is that the first question that came to my head is that before moving forward and making that decision to start intervening, with the asymptomatic, is the scapular dyskinesis test, a good test on the asymptomatic individuals. So that's the reason, this is the question, and that's the title of my presentation, whether it's accurate as a screening tool, right, for the asymptomatic people that will develop shoulder pain in the future. So that's the first question. So the aim of the study is to be able to establish the construct validity of the YNSDT against the EMG in the asymptomatic population. So now we're using the EMG as a reference standard. Remember I said earlier, and I've been trying to set it up that the way we intervene and understand this movement impairment is based on the muscles. So that's the reason why I chose to do EMG, is because what's the word? We've been trying to treat scapular dyskinesis with muscle exercises, and yet most of the validation studies, their references are simply just kinematics, and we still know right now kinematics has not been really good in detecting motion of the scapula. It's really poor when it comes to that because of the inherent position of the scapula, the bone itself underneath the skin. And so what we need to do now is establish whether the YNSDT is able to detect, right, or to be able to see, so to speak, what the EMG is seeing as well. So on this study, I had 38 healthy subjects that performed the scapular dyskinesis test and then recorded all the video, from the back, and then also collected data of the amplitudes of all the 4 muscles, right, on both sides. So that's a total of 8 muscles that were measured. And then on the video, there were 2 raters. There were 2 expert raters with more than 20 years of experience. Actually, they both have, they're both board certified specialists as well. And their inter-rater reliability is pretty excellent. Okay, so it means that they were agreeing a lot and when they rated the patients, when they saw the 38 individuals, they saw them and they said, okay, this person has dyskinesis, this person doesn't have, so they did the yes and no, and they were very good in agreeing. And what I wanted to know on this study is that if the YNSDT can discriminate, right, can it identify, right, the known groups, the symmetrical and the asymmetrical groups that was established by the EMG. So the EMG, right, by definition, based on its cutoff, the cutoff levels that was assigned to it, was able to separate these 38 people into 2 groups, whether they have symmetrical or asymmetrical scapular activity. Okay, and then the other raters, the raters that doesn't know this information, obviously, and they're independently rating, by the way, they're using scapular dyskinesis test to determine whether the person is symmetrical and asymmetrical. So to give everyone a perspective of, just a quick look at what it looks like in the lab. Let me see, how does this play? Of course, it's not playing, right? Give me a second here. It is not giving me an option. Hold on. Give me one more. I'm going to use my backup video right here. Can everybody see this one? This is another one. It's layover, right?
Yep. Yeah, we can see it.
Okay. I'm going to use this instead. It's a good thing I have this backup. Thank you. All right. So here I am. I'm going to play now. So here's the scapular dyskinesis test being done. And as you can see, the EMGs are placed on the four muscles on each side. 1, 2, 3, 4. That's the serratus anterior right there. And here I'm just going to orient you on what's going on. This is the left side. I should have flipped it, but this is the left side of the left side, and these are all the right side EMG. Right now, you'll notice that there is a 5th measure right here. These are not amplitudes. These are the gyros, the gyroscopes that is detecting the beginning and the beginning, the top, and the end of the motion. So as you can see here, there it is. These are the same EMG units, the units. And I only use the gyros in them and turn off the EMG. So it's not collecting any muscle on the deltoid. It's not doing that. And all it's doing is that it's just detecting what the location of so in here, so you can see here, I'll give you a little example. That's the beginning of the motion right here. Look at this line right here, okay? And as I move it on that's the top of the motion. You see it, right? There you go. So that's the highest that it would go. And you can see that by the time it gets put down, and that's the end of the motion. From there, just pretty much align all these together, and you'll be able to see when the muscles were active during those, from the beginning, top, and the end of the motion. That's what it tells you. Now, let me see. So we're done with this one. Let me get this out of the way. So moving along. All right. So now this is now kind of lay over. So we laid over the muscles on one side. So I'm looking only at the, I believe this is the right shoulder only of the patient, and it's showing all the four muscles laid over together. So you can see here, right? And I'm going to label them. So this is the serratus anterior. Okay. The upper traps is this blue right here. The pink is the lower traps. Okay. And this like really light blue here is the middle traps. What it's showing you, this is that same, lines that represents the beginning, the top, and the end of the motion. So this is where all the amplitudes are being captured for all the four muscles. So these are already processed EMG, and you can see that that's the reason why, it's very clear, the differences in the amplitude already. And here's that separation I was telling you about. So are we good? I guess everybody has a good idea of what I was looking for. Okay, so going back, I hypothesized that the YNSDT is not valid in identifying the scapular muscle asymmetry, okay, in the asymptomatic population. So that's my null hypothesis. And what I did, and I'm not going to go in detail on this one. We can have another session on how all the statistics were done, but I pretty much calculated for the sensitivity, specificity, predictive values, the negative and positive, the likelihood ratios, positive and negative, by simply using a 2x2 contingency table analysis. That's a very simple analysis. And however, I use a multivariate statistics called the receiver operating curve to be able to establish the EMG cutoff scores. So remember I told you that the EMG has to be able to classify, right, into two different groups, whether it's symmetrical and asymmetrical. As far as the EMG is concerned, this is the technique that I use to be able to develop those cutoff scores and make the EMG classify it. So maybe another way of saying is that my expertise, because I'm the expert, my expertise, I was able to hand it over to the EMG so that the EMG would be able to make that decision on its own. Does that make sense? Okay. And here are the results. Here we go. The YNSDT was not a valid test because it's lacking clinical value. That's what happened. All right, so let's look at it more in detail. This is the 2x2 table I was telling you about. Okay, so let me just orient everyone here. This is the EMG. 38 people, right? 38 people that went through the that whole process were identified as asymmetrical according to the EMG. There's 27 of them. And then the EMG also identified symmetrical people, and there were only 11 of them. So a total of 38, right? Now, the separate experts that did using the scapular dyskinesis test classified 22 patients or subjects with asymmetry and 16 with symmetry. All right, that's pretty close, right? But the problem is, where did they agree? No, look at this. They only agreed 15 times on the positive. So this is what we call the true positive, right? The true positive rate is only 15 out of the 27. And then when it came to the negative, they only agreed 4 times. There's only 4 true negatives on this one. All right. So if we using this 2x2 table, anybody can do this. Very simple arithmetic. You'll be able to get all these diagnostic accuracy metrics that I was talking about. And look at these. The sensitivity is only 56%. Specificity is only 36%. The predictive value is a little bit better, but then the negative predictive value is horrible at 25%. Now, the worst part here, which is pretty much important for a lot of us clinicians, is to really look at this likelihood ratio, because we know that likelihood ratio takes into account, right? It takes into account sensitivity and specificity when it gets computed. And the likelihood ratio is only 0.87 and 1.22. So in summary, the YNSDT disagreed with the EMG a lot, all right? Because the false positive rate is around 64%. False positive, where's the false positive? Right here, okay? And the false negative rate is 44% right here, okay? And also the YNSDT did not shift the probabilities in either direction. What I mean by that, according to Jeschke and his colleagues, the recommended interpretation for probability shift is this. So probability shift means that if you have, let's say you saw a patient and you deem that the person would, maybe, I don't know, there's like a 50% chance that they're going to get better. So it's just a toss coin, right? You don't know whether they're going to get better or not. Let's say you start with 50% chance because you're only confident on that level. Now, when it comes to likelihood ratio, positive likelihood ratio, meaning that you are confident that they have, the condition, anything greater than 10 is large and conclusive. That means that the possibility from 50% can shift all the way up to 100% if need be, right? And vice versa, meaning if you're trying to tell the patient that they don't have the problem, your negative likelihood ratio should be less than 0.1, right? And then the smallest number that is clinically important is a positive likelihood ratio between 1 and 2, and a negative likelihood ratio between 0.5 and 1. Where's ours? Look at ours, 0.87. It's even lower than the lowest, right? Clinically important. 1.2, it's beyond it. It crossed 1. So again, it's not even within that range where we can say that there is some importance to it. That's why there is no way that it can shift probabilities. So in other words, you can't really use it. So another way of saying is that what EMG saw, the YNSDT did not see that, okay? So in conclusion, the yes and no method of the scapular dyskinesis test may not be a useful in screening scapular dyskinesis in asymptomatic individuals. Again, if we're thinking to screen patients and that they might develop, future shoulder pain, we probably need another tool other than the scapular dyskinesis test. That's really the bottom line of the study. And so I'm not saying don't use it anymore. I'm just saying that consider maybe other tests because it's not as valid as you think it is. And that is it. Thank you so much. Any questions?
Thank you, Lawrence. That was very interesting, especially just to see kind of your thought process through that, and
Sure.
Obviously using the technology to help drive the study. I think, to start us off, has this work been published, or are you looking to publish your research on this particular topic?
Absolutely. They are already in line. So you are, what do you call it? You're getting a preview right now.
There we go. Lucky us. Hopefully that gets published up here soon then. So quick question. I guess on my end, I'm curious. So what are the implications of these conclusions? how would these results influence the way that you teach this test to your PT students?
Okay, that's a good question. In fact, that was that was asked of me during my defense, right? So now, really, what it means is that this is just one study, right? It's a good sample size of 38, but having said that, it is still one study. It's still useful, right? It's still useful generally, especially when it comes to the symptomatic population. This is pretty much talking about this is being now tested, so to speak, in the asymptomatic population, and it seems that where it's not really doing a good job so far. Having said that, like I said earlier, I would not. I would just be cautious. Is that probably is a better term to use? So just be cautious when you're trying to conclude and just say that, oh my God, don't scare your patient. Just say you're going to end up because of this you have scapular dyskinesis and you're going to end up with shoulder pain and just start scaring them. Think twice because apparently the test that you might be using is not as great as you think it is, right? It's almost like you go to use your bathroom scale, right? And then it's really not working, and then you keep saying that oh fine, I'm just gonna keep eating because I'm not gaining weight anyway. But in reality, you really are getting bigger and bigger, right? So that's really what it is. So just be careful, I would say, for most people. And I think there are and this opens up a possibility for possibly other tests to be developed.
Yeah, definitely. And I guess playing on that, we did have a question come in.
Sure.
What are the future investigations related to your finding? Do you have anything planned, or is I guess what are your ideas for future research?
Yeah, well, the thing that I don't know if you noticed, but I kept talking about the theoretical models as well, right? I'm trying to bring in. Typically, you don't really talk about those things, but what I really want to emphasize in this presentation is the value of theories. I mean,
Sure.
if you think about it, everybody makes an assumption of everything that we do. I mean, when you see somebody and make a decision, right? When you make a decision as to what you're going to give them, are you going to give them ultrasound exercise, a stretching, whatever, right? Any of those is pretty much based on on a theory, on an assumption that something will improve or something will not improve. That's always the case. So when I came in and made this, asked the question and started putting together the experiment, right, designing it and all that, I pretty much I was in this mindset of using these models, right, theoretical models. But then the overarching for me, the overarching realization, right, from this study and the rest of the other studies that came along with it, is that these theories were not very good in explaining that difference, or remember I said that the EMG is not seeing, or the scapular dyskinesis test is not seeing what the EMG is seeing. It seems that they're not in sync, that's for sure. But
Right.
Here we are as clinicians, we're always in the assumption, and I'm guilty of this. I look at somebody with like a wing, maybe, I'm going to give them the Y's, the T's, or whatever, right? I'm going to give them right away because that's the assumption. But here, it's indirectly telling us, right, that there is no connection between the two. That's weird, right? That's weird because that's the assumption that they are connected.
Right.
So the future is that, is there any other theory that may be able to explain why there is such what do you call this? Not discontinue.
Dissociation.
The dissociation, or why are they disconnected like that, right? There must be something else probably. So I guess what I'm saying is that, here you are making this assumption and what kind of, how you're going to treat your patient, and then it's not improving. Well, maybe you're making the wrong assumptions, right? I mean, that's the simplest way to put it. So that you can apply that same concept for this, the result of the experiment, and say maybe there's something else that I'm not really, I don't know yet. I don't know.
Right.
So I have an idea. So for that person that asked me, believe it or not, I'm really looking into more of theoretical models are more on the neurological side, right?
Mm-hmm.
Those are the ones, specifically what we call motor control theories, specifically what we call dynamical system theories. That's the one that has a lot of, for some reason, I can find a couple of explanations coming using that theory. So that's an interesting one too. So you better wait for the next presentation for the other studies that came along with this one.
That's right. And hey, watch out if you're a hypothetical model or theory, because you're coming for them, I guess, right? So yeah, we had quite a few questions come in, so I'll kind of just rattle these off just in order of how they came in. First one is, a little bit more related to the technical side of the EMG data. Specifically, can you better describe how you processed the EMG data? They're trying to determine how you used EMG to determine whether someone had or did not have dyskinesis.
Yes, that's the one I was saying, that it's very technical. I think the best thing to do, I would not be able to explain it without showing you everything that I did, right?
From a math standpoint.
Yeah, from like the math standpoint of it.
Mm-hmm.
So, but I think you have a glimpse of it. Like I said, I use a statistical technique called receiver operating curve. Believe it or not, receiver operating curve is not really special. It is a way to be able to figure out what the cutoff point is. Have you guys noticed, like, why do we use, I don't know, we say that 120 over 80 is the best, what do you call this? Blood pressure, right? Like it's the best, or normal blood pressure. But somebody has to make that decision first, right? Somebody made the decision that it's 120 over 80. Our BP apparatus only measures, but it doesn't tell us whether it's normal. So that was the same concept that I applied to the EMG. That's why I kept saying earlier, there is an expert first that's gonna say that 120 over 80 is the best. And that's the cutoff that's gonna be, measured. But it's not as simple as that. But what I'm saying is that when these numbers were determined, there is a process, and one of them, a good example, is the use of the ROC, or the receiver operating curve statistics, to be able to find that best number. It's a balance between, maybe to make it simple, it's a balance between sensitivity and specificity, really. That's really what it is. And because it really is about the likelihood ratio, the positive likelihood ratio. And that's, and finding the best balance that would give us a good specificity and a good sensitivity at the same time. And that's what it did. But there's more to it, obviously. And I think maybe if we can discuss that more in detail. But as far as the processing, I mean, that is the magic of MR3, right? I'm going to tell you, because I've used other systems before, but what's great about the system is that I was able to apply all the, what do you call those?
MVC calibrations?
Yeah, all of them, everything that I applied to it to be able to turn it into what you've seen, right?
Sure. Smoothing.
All of that, all of those were already in that system. And the best part of it is done in real time. See, so when I was capturing, that's why I decided to put that video along with the, with what, during the real time capture of it, because you can see that in real time. It's already processed EMG. That is it. It's not raw anymore. And that's why it was so beautiful, because right off the bat, I already have an idea of what's going on, just what do you call this, qualitatively evaluating it. I already have an idea. And you can see it on that Zoom version. You you can tell which one is the most active versus the least active. You can already tell that the serratus was just firing like crazy versus the middle traps for every repetition, right?
And then, so as far as the parameters that you extracted for those statistical methods, was it predominantly just amplitude parameters? Were you looking at okay, so it was just looking at the symmetrical comparison between those amplitudes. Okay.
Yeah. So maybe to give it a little bit more information, it's simply it's as simple as measuring the two sides, right? The two, let's say the serratus anterior. I measured the two sides, right, and then subtracted the difference. I mean, as simple as that. So the question is, so after you have determined that these people are, symmetrical or asymmetrical based on the expert, right? You subtract those numbers and just get the average of all these people. That's really all it is. But then you apply other, statistics to it to be able to find that cutoff.
Okay.
Okay. Yeah. So I can share that for those who want to do further studies using, this technique. Yeah, I'm open. I'm okay. Collaboration.
Oh. Yeah, that's right. That's what we're here for.
I would like to write that paper with you, whoever you are.
All right, so we got a few more, and I do want to be conscious of everyone's time. It looks like we might be slightly going over the hour, if we get through all these questions, but I think they're all very great questions to address, and so we'll go ahead and keep running through these. Let's see here. Do you think that looking into shoulder strength asymmetry would also be important to consider in dyskinesia?
Absolutely. That's a really great question. So I'm sure a lot of people are asking, why is manual muscle strength not measured here? Well, first of all, unfortunately, it has been shown to be not statistically different between the groups already. That has been shown already. I've done a pilot study that did that. There are other studies that have done that as well. However, that's not the only reason. All right. The main reason is that we all know this. When we do resistance, right, manual muscle resistance, that is a co-contraction of muscles around it. So we can't really specifically say that we are only, even with the best positioning, the best stabilization, no matter what you do, it's always a combination of other muscles because of the synergistic, relationship between the muscles. So that's why the EMG is the best when it comes to just honing in one particular muscle. Again, assuming that the EMG is able to also minimize the cross talk, right? I mean, we're talking about so that's the reason why we clean it really well. We put it right on the spot and all that. So you just have to believe in yourself that you did everything you can to minimize all that. But that's one of the main reasons why that is not generally considered when you're trying to specify or trying to name one muscle, in experiments like this. But that is a great question.
Yeah. So clinically, it obviously has its a major impact in determining dyskinesia.
Oh, you know what? It's funny. Yeah. Okay. So like clinically, I guess the one of the kind of conclusion here is that don't be like me, right? In the clinic, I was one of those that I'm like always in a hurry. I look at somebody, he has scapular dyskinesis. I'm going to give you this exercises. We're not even testing for the muscle strength. That is ridiculous. You should not do that. So that is one of the, what do you call this? Like conclusion is that you really have to do your tests. Sure. You cannot prescribe any exercise only based on the movement that you see on the impairment. You really have to test it and then give the exercise specific for that impaired muscle. And I think, that's what we've been teaching our students, and that's we should be continuing in the clinic as experienced clinicians.
Okay. Mm-hmm. Let's see here. Would you recommend EMG at this stage for screening professional athletes for shoulder dyskinesis? And do you think there's a cost benefit there, or
It
Not.
could be. It could be. I can't tell because the experiment was not geared to that, right?
Sure.
It was more about using it as a reference standard. But again,
Yeah.
if I use it as a reference standard, I'm really considering it as the gold standard. That's what I'm doing, and that's
Right.
what I did. So I believe that is if you want to be a little bit more specific on your rehab, I would say that the ENG is a way to go. I would start recommending it at this point probably just because of my experience and how good it is, right? In giving me that the direct comparison, especially the ability to do it in real time because that's what you
Sure.
need in clinic. So having said that, it looks like it's at this point it is very useful now.
Sure.
I would not recommend it back in the day because you still have to process everything. But now that like Naraxin or the MR3 is able to do it in real time, nobody's stopping you at this point.
Yep.
Mm-hmm.
Let's see here. Got a couple others that came in. You had indicated earlier in the presentation that you were mostly interested in the 4 muscle groups. Those muscle groups did not include the rotator cuff.
Yes.
Is there a reason that you did not consider the rotator cuff, which certainly plays a role in the shoulder movement?
That's right. They were not. First of all, okay. First of all, they're not scapular muscles, right? So
Sure,
I was specifically looking at the muscles that specifically control the scapula. Okay. Because at this point, I was not concerned whether the glenohumeral joint is moving or not. I mean, well, I am, but I'm not measuring any of those. That's one. I even used only the gyros to tell me whether it's up or down. That's all I'm doing.
Sure. Okay.
So I'm not even concerned whether, how many degrees or anything like that. That was not my concern. The other thing about it is that, although he's right. You're right. That the rotator cuff muscles are very important muscles though. But like I said, it's not the focus of the study. That's why it wasn't included in the study.
Okay.
I think that's the main reason for it.
Yeah, makes sense. What about using the upper body Y balance test for scapular asymmetry? Is that something that you think would be useful or a good idea?
How about we test it?
There you go. You got another research.
All right,
study.
we have a study here developing as we speak. I don't know.
Sure.
That's the
that was valid answer.
My answer. I don't know.
That's a valid answer. So yeah, there you go. You got another study on deck. That's what we're doing here.
Call me.
Let's see here. We've got a couple longer questions that I have some information to read off. So give me a second here.
Sure.
So this one states regarding the Hickey article that indicated a 43% increase of shoulder pain. A few studies have questioned these results, though.
Absolutely.
Hogan et al. Noted that both static and dynamic tests for scapular dyskinesis were used, contrary to the expert consensus, and the pooled number of injuries was below the statistical recommendations for the risk factor identification. And then Littlewood and Cools also questioned this study, which showed a wide risk range. A wide risk range of 1.05 to 1.93. What was your assessment of their methodology, and would you use these results going forward?
Yeah, so I'm sure you've noticed that I kept nodding because I already. I mean, when fortunately, when you're doing your dissertation, you really have to scrub the literature, right? And so yes, I've seen this, and if you actually read my literature review, there's a section there that talks about this, and the question, why is it questionable? This particular study is questionable. And I agree with all these commentaries that were done against it, right? Yep. And however, when you looked at it, you have to remember these were all the prospective studies at that time when they did the analysis, right?
Sure.
And Um, I'm going to tell you, with the best of my knowledge, I thought they really did a good job, except that they minimize some of the flaws that, instead of putting it out there and making it clear to the public, right? I think that was their fault. That was the only fault they did. But I mean, the numbers are there, especially the
Sure.
Coles, about the wide confidence interval, very close to one, which is like nothing, right? I mean, that's true, right? That's true, and that's the reason why there is validity on those comments. Now, the problem is, I'm not the problem is now. So what I did to be able to be fair to the Hickey group, right? What I did was I did another, actually I did another presentation separate on this one. So maybe we can do another one. What I did was I literally, remember I told you that I read that Hickey paper, like top to bottom, like crazy. Okay.
Mhm.
What I mean by that is I was able to reproduce the 2x2 table using the numbers that they presented there, and I was able to reproduce it. And I did my own analysis, right? And really, there is a technique that you can do, other statistics that you can compute that would give you a little bit more information on that relative risk. Although relative risk is good, right? The problem with it is that it's like any kind of ratio. I mean, the absolute value of those numbers just goes away. So that's the reason why you need to do other statistics that will be able to give you more information, such as number needed to harm or treat. That would be a good one too. And then what we call the population attributable fraction. When you compute for those, it gives you the real truth, I would say, so to speak, truth about that relative risk number, that 43%. So I guess what I'm trying is I was trying to play, what's the word, like a devil's advocate? Is that the right word?
Yep.
So I did that. And that's the beauty when you write the literature review. You really have to show both sides, right? And then pick a side after you've done your experiment. So so having said that, I do agree with that person pointed out all those things, because but like I said, there were things that I also looked at to be able to make it fair for the Hickey group as well. And then from there, you make your decision based on your experiments. Mm-hmm.
Let's see, we got basically two more
Sure.
To address. And for those, if there's any left that's need to sign off for any reason, we will have this as part of the recording posted. So if you do need to sign off, don't worry, we'll include this discussion as part of that recording that we post and send out. But so I think this is a good question. So this is asking, what role does variability in the presentation of dyskinesis play in your data? If there is a large range of different dyskinesis patterns possible, and thus a large range of different muscle activation patterns available, especially over a full range of shoulder elevation and depression, it would presumably be very difficult to determine or detect whether EMG and dyskinesia are related to each other.
That's right. So it's funny you mentioned, whoever you are, I like you because you started mentioning the word variability. So when in the other part of my study really looked at this in detail, right? And this is not, I'm talking about, I started looking not just in amplitude, I looked at the timing, I did timing analysis. I mean, you name it, everything that MR3 can offer, I started looking at it. Because what I really wanted to do is I really wanted to see the differences, right? If there is anything. But the conclusion of my other aims found that, what do you call this? There is a ton of variability really happening within these muscles. And that's another reason why I somewhat made making a conclusion that truly scapular dyskinesis could be a normal thing. In fact, it could be something that we might need to encourage. Now that's different, right? We're talking about encouraging it now, right? And I think that's the reason why like I said earlier, there must be another way to be able to explain it. Why why this is happening, because it seems things are starting to point towards the direction that it might be a normal thing due to the amount of variability that we see. And that is very true in gait, right?
Yep.
Gait, we see a lot of variability. That's apparently normal. So
Right.
it's kind of like the same principle, or I guess what's being revealed when it comes to the world of scapular dyskinesis. So it's really interesting. There's a lot more to look at, that's for sure.
Yeah, it seems like you're just starting to uncover some of these things.
Yeah, just like barely scratching the surface. That's
yeah.
true. Mm-hmm.
Great. That's seems like it's going to be exciting then for a nice career in research here for the next few years.
Hopefully.
All right. I think we're down to the wire here on the last one. So in regards to the intervention studies that you mentioned early on, would you refrain from SCAP intervention exercises in a population with little to no shoulder issues? And what if this population was overhead athletes? So I think that's actually a good question to maybe end on, as far as kind of the application of, these conclusions and how that has what implications that would have clinically.
Yeah. So based on the results, right, you would think
Sure.
that, well, let's not do anything about it. No, I think at this point it might be a little too early to say that.
Sure.
I'm not going to say that yet. I think the best way to look at this is that, like I had mentioned earlier, if we are to intervene, right, regardless whether we are working on somebody who has pain or no pain, I think the bottom line is that you still need to treat based on the impairment that you are seeing. So in other words, if somebody is truly tight or short or whatever, right, or weak, I mean, just still address it as it is, regardless. So I'm not going to go as far as recommending, right, not to do some exercises for anybody, because what if this person truly has a form of weakness or whatever, right? That still warrants some intervention. So I'm not saying that. I'm just saying that the test itself is probably not as great as we think it is.
Okay.
That's really all it's saying right now. So unfortunately, I cannot make that leap. That would be dangerous.
Yep. Exactly. Yeah. As I think that's totally fair, and exactly what we've identified up to this point, right, is that there's more research that needs to be done to look at these different models and then determine what that pathway is forward. So
yeah. Well, I guess maybe when we get to the point where we can do like a trial, like a randomized trial,
sure.
where we would we'll try this result, we're going to validate it and say, I don't know, like get these people, treat them prior to whatever, and then don't treat the other side and see what happens.
I mean,
that's really how you're going to really say whether that, oh, I'm not going to treat it anymore because there's nothing, I don't really need to, but you can't say that until you do something like that. We're just right now making assumptions based on the result of a small study like this. So that's why I encourage people to throw in these beautiful questions that you have and partner up with anybody that will be interested in answering these questions as well.
Great. Well, thank you so much for your time, and we really appreciate your work, and definitely look forward to the next opportunity to do another presentation here. And thank you everybody for joining us and your great questions and sticking around. I know we went over a little bit on our time today, but definitely appreciate everyone staying with us. Lawrence, I hope you have a great rest of the week and a good Memorial Day weekend.
You too.
We'll talk to you soon, okay?
All right. Thank you, everyone. I appreciate
thanks, everybody.
I appreciate it. It was my pleasure.
Okay. Appreciate it. Thank you. Bye.